Ladies and gentlemen, thank you for standing by and welcome to the Perinatal Quality Collaboratives webinar series. During the presentation, all participants will be in a listen-only mode. Afterwards, we will conduct a question and answer session. At that time, if you have a question, please press star followed by the 1 key on your telephone. You may also enter questions at any time throughout the webinar by using the chat feature located in the lower left corner of your screen. If you need to reach an operator at any time, please press star 0. As a reminder, this conference is being recorded Thursday, May 21st, 2015. I would now like to turn the conference over to Dr. Henderson. Please go ahead.
Hello, everyone. Good afternoon. My name is Jaquiba Henderson, and I lead the state-based Perinatal Quality Collaborative activities in the Division of Reproductive Health at CDC. And I'd like to welcome you to our next series of webinars we're sponsoring on Perinatal Quality Collaboratives. Today's webcast will present a discussion of quality improvement initiatives addressing engagement of patients and families to enhance the collaboration to improve perinatal outcomes. This is part 1 in a 3-part series on patient and family engagement. At the end of this presentation, you'll have the opportunity to ask questions and participate in the discussion with the presenter. You may also submit questions via the chat function. A recording of this webinar will be archived on our webpage at www.cdc.gov/reproductive health/maternal infant health/PQC. Handouts for this presentation were made available with your reminder email after registration for the webinar, and will also be made available again to registrants in a follow-up communication after the webinar. Our speaker today is Tara Bristol. Tara Bristol currently serves as the Director of Patient and Family Partnerships for the Perinatal Quality Collaborative of North Carolina. She has over 8 years of experience as a patient family advisor, serving as a partner in quality initiatives, and over 6 years experience coaching statewide and national hospital teams on engaging patients and families in their quality improvement efforts. This includes faculty roles with the Institute for Healthcare Improvement, the National Institute for Children's Healthcare Quality, the North Carolina Hospital Association, Patient and Family-Centered Care Partners, and others. We are very pleased that she will be sharing such an important topic with us today. I will now turn the presentation over to Tara.
Thank you, Kiva, for the introduction. It is such an honor to be a part of the webinar series and to share what truly is, as Kiva mentioned in my introduction, a very personal area of work that I'm so passionate about. So today, as we have this discussion, and hopefully we'll engage in some conversation together at the end, as Kiva mentioned, it's part of a 3-part series, and today we'll be really doing an overview of patient and family engagements and sharing some examples of this work in Perinatal Quality Collaboratives. So whenever I begin discussions about patient and family engagement, I love to start with this image. And if we were in a room together, I would have you shout out and tell me what it is you see when you look at the image. But since we're not, I'll skip to the punchline and say that usually when I am in the room with folks, we'll say, some will say they see a rabbit, and others will say a duck, and even others will say that they see both of these images. But the point being that we're all looking at the same picture, the same image at the same time, and yet our experience of that image can be very different. Well, the same can be said of the clinical settings in which we work. The experience of a patient and family member during their time in the hospital, if you ask them to talk about it and reflect on what was important, what went well, and what didn't. It would be very different than the response that would be given by the providers oftentimes. And so I truly believe that we need all those perspectives to get a full picture of how care is provided and received. And so it's not without everyone at the table that we can really do the most effective job of improving healthcare outcomes. Now, in 2012, we started to hear patient and family engagement referred to as the blockbuster drug of the century. And that's not to say that it wasn't important before that time or that folks weren't, it wasn't recognized, but that's when we started to hear a lot of terms related to patient and family-centered care and patient experience bantered about. So I wanted to start us out and make sure that we all had a mutual understanding or some agreed upon definitions. And so I'm going to give folks just a second here to read through these before I provide a little bit more comment on these definitions. So as you read through these, you'll see we've provided sources for the definitions, and it really, while there are a few differences in how you'll see these terms defined across organizations or bodies of work, they're all pretty similar, and these are some of the leaders, thought leaders related who have been sourced here. One of the ways that I like to think about the difference between patient and family-centered care versus patient and family engagement is a friend of mine said, patient and family-centered care is really the noun, and patient and family engagement is the verb. It's the action. It's what's making it happen. And so that's kind of one of the ways I like to create between those two concepts. Patient experience, of course, anyone who works in the hospital is hearing a lot about that, and even in outpatient practices, really with HCAPs and things that are becoming more and more tied to payment. And then at the bottom, patient and family advisors. Some hospitals or facilities use the term advisors, others like to use partners or other nomenclature, but for the purpose of this presentation, you will hear the name advisors to talk about patients and families who are partnering on improvement efforts. But beyond the list of definitions, I think, conceptually, when you think about what does it mean to engage and partner, I really like this model that actually comes out of the Netherlands and some of their patient and family-centered disabilities work. So many times you see when patient and family-centered care is talked about, you've got a little circle, and it's got the patient in it, and then there's a circle around it that's got the family, and then maybe the next circle is providers, but it's got the patient and family at the center. I really prefer this visual, which is having everyone as equal partners or with co-responsibility working together in partnership. So with all the core concepts we think about when we think about patient and family-centered care, information sharing, collaboration, participation, partnership, dignity, and respect, thinking about it in terms of doing things not to or for patients, but doing things with patients. And I mentioned that in 2012 we started to hear more and more about this concept, and it was so much the payment reform. But this has been going on a while now, and for some organizations, this has become a foundational priority. So in other words, they're investing time, money, and people into this work. I've listed up here some of the leaders in terms of they've really invested quite a bit in terms of resources, and they're nationally recognized, respected organizations that are finding ways not just to engage patients and families in the work that they're doing internally, but also to support other facilities, hospitals, and other organizations in doing this work as well. So I think it's important that for those of you on the webinar that we recognize that this isn't something that is the nice to do, nice to think about thing, but this is something that's really seen as valuable by very respected leaders in healthcare. One example here I want to provide, this comes from MedStar Health. So many people on the line may be familiar with Six Sigma and quality improvement, so becoming a really highly reliable organization in order to optimize outcomes. And one of the things that MedStar attributes to its success is they focus not just on the things many of you are working on to improve outcomes, like using evidence-based practice and hiring the right folks and making sure that they have the right training and support, but going beyond that to partner with patients and families to make sure that, again, we want this reliability, and that the only variation in healthcare is that comes from the needs of the patients and families. Now, with all of this work going on and so many leading organizations investing resources in this work, there have come some kind of frameworks or models for how we might engage patients and family members. This is one that I happen to like, and you can see here that on the left there are different levels of engagement. So maybe you're looking at direct care or bedside engagement of patients and families, or maybe you're working more at the organizational design and governance level, which would be applicable for a lot of folks who are working in perinatal quality collaboratives, or the policy-making level. And for the purpose of our discussion today, I'll stick with the red boxes since we're talking about quality collaboratives. But you'll see that there really is a continuum of engagement. And so, and maybe that you start out with patients and families in more of a consultative role. That's where, let's get some feedback. Let's send out some surveys and see what patients have to say, and then we'll bring them back to our committee and look at them and make changes based on what we see. Or maybe you're evolved to the level where you've got maybe a patient or family advisory council, and so you meet with them once a quarter or once a month, and you get feedback from them on issues and take that feedback and make changes. Or maybe you've evolved further to the partnership and shared leadership level, where this is the co-ownership, co-responsibility. And so it's not going to a group of patients or family members and getting their input and then going and internally making it happen. It's really having families in leadership positions alongside you, making decisions and making things happen. And, what you'll find, I'm sure, in your home institutions is that not every unit or care area or part of your organization is in the same place in this continuum. And even within a department, you may find that for some of your work you're at one level, and for other parts of your work you're in different levels. And so you may find yourself moving back and forth on the continuum with different work that you do. Another framework that comes out of the American Hospital Association, which is a little bit different, it's still looks at kind of the bedside engagement level, which would be the individual and healthcare team framework, but looking also at organizations, but community too, because we know that so much of health happens outside of the healthcare system, and so it's a really important area when we talk about engagement efforts. But no matter where you are on any of those continuums or frameworks, what we know is that just having a patient and family representative in the room changes the conversation in every way. Jim Conway is a former senior vice president of the Institute for Healthcare Improvements and is former chief operating officer for Dana-Farber Cancer Institute, and has done a lot of work in patient and family-centered care. But I think anyone who's spent any sort of time bringing patients and families into the work of their organization will be able to say, even if you have a patient or family member who is kind of sitting there part of a committee or team or meeting, and even if they don't say a word, it changes the way we work and changes the way the conversation happens. And so even if you aren't at this co-leadership level, just start, because it does change the way that conversation happens. Of course, especially when you're talking about organizational change and leadership, it's not just any patient or family member that can be a part of that work. You really need someone who displays certain competencies to be a partner. And when I say that, I'm not talking about their educational level or what kind of background they come from. I really love the concepts that and competencies that come out of patient and family-centered care partners when they talk about who makes a good patient and family advisor. Of course, you want someone who is solution-focused, so not bogged down in what went wrong, but how can we make sure this doesn't happen again? Someone who's a positive, constructive collaborator who can get beyond the negative aspects of care. Someone with a representative voice, and so someone who is not so focused on their own personal health care journey or that of their loved ones, but can see beyond that to how can we help healthcare users in general, and what aspects of my own personal journey in healthcare can I look for themes that will be applicable to others in other patients and family members coming through the system. We also want people who have a teachable spirit. And what that means is that it's someone who doesn't walk into the room thinking, I'm going to go in there and I'm going to tell the providers this is what needs to change, this is how it needs to change. But they're willing to go in and know that they have so much to learn and can be a part of that process and have a teachable spirit. And finally, just someone who's able to establish partnerships, because that's what we're doing after all, is partnering together in this work. The roles of patients and family members are many. This definition was put together at the Institute for Healthcare Improvement Forum in 2012. There were about over 20 patient and family members from across the country who worked in urban and rural settings, inpatient, outpatient settings, a real diverse group. And we sat together and came up with kind of all of the roles that we have had as patient and family advisors. And what you'll see as you read through this definition and think about, how you are working with patient and family advisors and how you might in the future. We talked about, again, one of those core competencies coming back, that they're able, the stories are used as teachable moments to represent patient and family experiences. These are individuals who are authentic when they come in to partner with you. They don't come in with a, here's my issue and I'm going to get this dealt with because this happened to me, but they authentically, truly want to improve the system, and they're there as a collaborator. I wanted to provide an example of how partnering with patients and families can improve outcomes. And this is pretty exciting data because it's still kind of hot off the presses for some people who don't live in this world, and they're just starting to write up the results of partnership for patients. But for those who aren't familiar, Center for Medicaid and Medicare launched the Partnership for Patients campaign in 2011. And it really kind of kicked off more in 2012 with the work of 3,700 hospitals participated by way of 26 hospital engagement networks. So these networks had groups of hospitals working with them towards these goals. And the two overarching goals were first 40% reduction in preventable hospital-acquired conditions and a 20% reduction in 30-day readmissions. So they're models for getting this work done, and you can see there the little blue circles in the middle, which has the preventable hospital-acquired conditions in it. That this is how we were going to get at this issue and improve outcomes. And you'll see that patient and family engagement was a huge part of this. And so of these 3,700 hospitals, they were being asked to take on this commitment to engage patients and families as part of this work. And so here were the measurement criteria that were given to these hospitals. So at the point of care, the first goal you'll see here was a planning checklist with patients and families. So what that means is that for any planned admission, that before the patient came in, there would be a discharge checklist, essentially, that they would be able to go through to really know what to expect, what needed to happen before they went home. So they have that anticipatory guidance. So that was one aspect of measurement. The second one was that there would be change of shift huddles for the staff and bedside reporting that would include patients and families. Under more policy and protocol, the third criteria was PFE proactive responsibility. So what that means was that there would be either an individual or a department, some entity within the hospital that would be responsible for patient and family engagement. And that as part of that, there would be a measurement of effectiveness. So they would be looking at what are the strengths, what are the needs in terms of patient and family engagement. Fourth was having an active patient and family engagement committee, whether that be a patient advisory board or some other committee, or an advocate, or someone who had received care within the hospital who was sitting on a quality improvement committee or a safety committee, something of that like. And then falling under governance, it was a requirement of having a patient representative on the governance or leadership board. And this shouldn't be kind of what we think of, there are a lot of healthcare systems out there who the patient or family member who ends up sitting on the board is oftentimes a big donor, and that this needed to be really an authentic representation of the patient population. So this was part of the framework and measurement criteria that was put out there for those participating hospitals. Carolinas Healthcare has been one of them, the hospital engagement networks that shared some of their data so far. And this was pretty exciting to come out because what you'll see is on the red line are in terms of patient and family engagement, they don't call it the low performers, but they call the other cohort. The blue are the high performers of patient and family engagement. So these are the groups that are of those criteria that I just showed you, had 4 or 5 of those that they had accomplished, and compared to the other cohort who had not accomplished that goal. This particular measure is the perinatal core measure for early elective deliveries. And so you'll see that there's a pattern, and we can't call it a formal relationship here, but you'll see that it looks as if those high performers in patient and family engagement performed better in terms of having fewer early elective deliveries. In Minnesota, their hospital engagement network was another one who looked at their outcomes stratified by high performers and low performers for patient and family engagement. And here you'll see the orange line. These are the low performers, so they met 0 to 3 of those criteria that were shared, and the high performers who met 4 or 5 of the criteria. And this happens to be the readmission rate. So, what could we possibly have reduced in terms of readmissions? And the high performers, again, there's a pattern of better outcome for that group than the PFE low performers. So this was really thrilling data that came out. This is just another way of looking at some of the Minnesota data. They worked with some patients to develop this campaign and really love the way of looking at this visual where you can see that each person in the picture represents 250 prevented readmissions and 1,000 more nights of sleep in your own bed for Minnesotans. But really exciting work that came out of Partnership for Patients, and more is being written up, and they're going into round 2. So 2015 will have more hospital engagement networks or groups working on this Partnership for Patients and reducing hospital-acquired conditions in partnership with patients and families. So with all these great organizations working on this and all this amazing data coming out, why is it that everyone just hasn't jumped on the bandwagon and brought patients and family members in to be partners in their efforts? Well, for a lot of folks, it's because we are very afraid of what it might look like out there. What treacherous waters am I getting myself into by bringing a patient or family member in on a council or committee with me or in a leadership role? And a lot of times it's that they feel like, gosh, there's going to be a patient coming in and telling me everything I did wrong and that here's what I need to do to fix it. And that's why I mentioned earlier, it's about bringing the right folks in who have that collaborative spirit. I love this quote from Beth Kreider because I think it really is a good way of summing up what collaboration really means and should look like. That no one interest group is always right, and it's taking what you think and what I think and what someone else thinks and coming up with something that works for everyone. So as we move forward with this, it's that there must be an understanding of what collaboration actually looks like. This work also hasn't happened faster because this is changing culture for a lot of people. This quote came from one of our hospitals in North Carolina from a nursing staff We had just done a Patient Safety and Awareness Week campaign where families were given information on some of the safety procedures we have in the hospital, like double-checking IDs and hand hygiene and these things. And when we asked staff what they thought about it, this was one of the comments. We are professionals with a licensed practice. We don't need families to let us know if we do it wrong. This is a big shift for us. Now, another thing, and I don't think we acknowledge this enough, but patient engagement is a skill. It's not something that we are all born able to do. And I know many of you who are providers will echo this. It's not the way that you were trained when you were in nursing school or medical school. It's a different way of practicing, and it is not something that you were necessarily prepared for. So this is another big stumbling block that can be out there for those who, maybe you really want to engage patients and families, but you're not quite sure how to do it. And then, there are those who, we want to do it, we're going to do it, but there isn't really a strategic plan for making it happen. So this quote is from Don Borwick, formerly with CMS and with the Institute for Healthcare Improvement, probably familiar to many folks on the webinar today. Hope is not a plan, some is not a number, soon is not a time. So how do we get beyond that and really put it into practice in a strategic way? And so now I want to share a story with you, or our journey with the Perinatal Quality Collaborative North Carolina in our patient and family engagement efforts. Because I think, as a quality collaborative organization, we have the same stumbling blocks as I just stated in moving forward with this work. Whether it be the teams that we're struggling with this at their institutional level, or internally, how do we make this happen? And so one of the first things that we did when I was brought on as Director of Patient and Family Partnerships was to develop an initiative, just like we would any of our other quality initiatives, specific to patient and family engagement. So this was the mission of this work. We created an action plan, just like we would any of our clinical initiatives. And kind of the main outcomes we were looking for was these, that we wanted folks to have a process in place for identifying patients and families. We wanted facilities to contact at least 3, and this was over each of 2 4-month initiatives. So in 4 months, we want you to contact 3 potential patient and family members about assisting you and your team with your improvement efforts. And then of those 3 you contact, we want you to get, in 4 months, one of those folks to come and be a part of your improvement team meeting, or participate by phone, or in some way be involved in the work. And we also want you to reach out there and maybe try to get at some of the cultural issues that I mentioned, and help support and educate staff in engaging patients and families. So this was the action plan that we set out with in our work. And the way we supported this in the 4 months, we had 2 learning sessions, one at the beginning of the initiative and one to close it out. But the initiatives were a time not just to provide hospitals, we provided them with education by bringing in wonderful speakers who were doing this work in hospitals throughout the state, but also we're providing tools to them. I hope that many of you will find this as a familiar template to you. Down in the right-hand corner, you'll see the AHRQ logo. They have a guide to patient and family engagement that has PowerPoint and Word documents and brochures and flyers and everything you could want as you're starting your journey with engaging patients and families. So we not only used the template to educate the people who are at the learning session, but to show them that this was one of the very turnkey tools that they would be able to use as they went back to their home institutions. We also wanted to provide support for those who were leading this work too, because a lot of the people who showed up to the learning sessions were like, yeah, I'm the one who's been identified to do this work, but I have no idea what I'm doing. You know, I'm a nurse on a unit. I have no idea. And so a lot of what we needed to do was support teams in terms of how do you lead this work? How do you help move your department forward in this effort? And tying it back to quality improvement, because again, this isn't just the nice to do stuff and the fluffy stuff, but these are tests of change that you can use and try out in terms of, you know, what is the best way to identify family members who could potentially be members of our advisory committee. So we really worked to really bring home that these are things that you should go home and test out and report back on and collect data on. We provided a lot of resources on our web too. So, and I absolutely invite everyone who's interested on this webinar to visit the picnic website, which has, if you go down to initiatives and patient and family engagement, a lot of resources that our teams use. And so, you know, we pulled from kind of Institute for Patient and Family Centered Care, AHRQ, articles from Health Affairs, other things that we knew were kind of vital and highly utilized in the field, putting them all in one place for our teams. We also, as we would for our other clinical initiatives, provided monthly webinars that were partially content-based and also covered having teams share what they had been working on, because as folks who are interested in quality collaboratives know, one of the absolute biggest benefits of being part of a collaborative is being able to learn from one another. And so it was that team sharing that was a huge part of the patient and family engagement initiatives. Again, emphasizing this is quality improvement work. We had teams report on what they were doing monthly. And so, you know, who's working on this? When is it going to be done by? You know, how are you going to know whether this change was a success or not? So emphasizing that with teams. And of course, along with all of that, there was data collection that went along with this. And so for us, the first initiative that we did for patient and family engagement was really, you know, the numbers, you know, how many folks have you contacted, how many of those agreed to assist, things like that. But it was so important to tie the data to that, because patient and family engagement work, it's very easy to just kind of do it without tracking what you've accomplished. And so putting this in place, a structure in place for collecting this data, was a huge thing for many teams, and why some of the teams that participated have been doing amazing work in the state in terms of partnering with patients and families, but they came on board because not just to share their successes with other teams who were just beginning, but also they needed to put this structure in place as well. So we ended up having 2 4-month initiatives. So out of our 8 months that we conducted this work, we had 15 hospitals that participated. And over those 8 months, they ended up contacting 166 patient and family members about potentially being partners in their work. And so on average, about 55% of those patients or family members contacted agreed to help assist in some way, whether it be participating in in-person meetings or just saying, I'd be happy to participate over email. So just send me stuff you want me to look at, or I can join by phone or web, but not in person. So in some way, 55% agreed to assist. And during the second initiative, so during 4 months, we started to track, what part of the return on investment of this is the volunteer hours that the patients and family members are putting in. So in 4 months, the teams tracked 220 volunteer hours that came from patient and family members, which is absolutely huge. And one of the things that was so important with collecting this data, so that teams could go back and be reporting this to their leadership, that this is one of the benefits that came out of this work. And also over the course of the 8 months, over 1,200 providers were educated regarding patient and family engagement, techniques, best practices, and so hopefully, getting at some of the culture change. Some of the, outcomes that we would have loved to look at, in terms of satisfaction scores or other outcomes, because of the time-limited nature of doing a 4-month initiative, these mini initiatives, we really weren't able to collect that sort of data. But our hope was just to provide this structure and framework so that as we move into our clinical initiatives, and what you see up here is part of our action plan for our current preeclampsia initiative that we're working on, was that the momentum built in those 2 mini initiatives would follow the teams through so that they would be able to engage patients and families in their clinical initiatives. And so this is just a little snapshot to show the work is continuing now, not within their own exclusive initiatives, but within the current clinical initiatives, and working in a stepwise manner to really position teams to be able to effectively engage family members in their work. Because at the end of the day, what we want and what we know is going to lead to the most reliable care and the best outcomes is to have family members working in partnership with us. Some of you may recognize the man in the picture here standing and holding the sign that says 199 days since the last infection. He was in one of my initial photos during the presentation holding his baby daughter. His name is Jean-Paul, and he's been working with us now for a number of years. His involvement actually came from his daughter dying of a preventable infection in our NICU after 6 weeks in the NICU. And so after she died, baby Gabby was her name, he said, how can we make sure this doesn't happen again to another baby or another family? And he then became involved in our work with Picnic, and as we were doing our catheter-associated bloodstream infection project. And this is him at the end of the initiative with our team, holding up a sign that said our team had gone 199 days. And then this picture was taken since the last infection. So, these are the kind of stories we want to have, where we can turn examples of where care didn't go as it should have, or wasn't the best care it could have been, and turn it into experiences where we can partner and improve the way that care is provided in the future. So before I kind of wrap up my talking portion, I wanted to leave you with just some tips for successful patient and family engagement efforts. One is to identify champions to drive this work. One of the easiest ways to go off the rails is when you're like, yes, we need to do it, and you're kind of doing it, but no one's really taking ownership of it. So identify people who are passionate about this effort to partner and to take ownership of it. Set up systems for continuous communication with patients and families across your team. So making sure that they always know who they can contact if they have questions or concerns, even if it's just that they can't remember, did we change the meeting time or not, that they always know who they can go to. Remain open-minded and agile. This work, it can be a lot of trial and error, and so it takes patience and flexibility to be able to do this. Be present and actively participate to maximize collaboration. I think there's so many wonderful leaders. As I've seen the folks on this call, some of the names that are familiar, they're leaders on this call, and I challenge you and encourage you to really actively be part of this process of partnering with patients and families, because giving a blessing is important and one thing, but actively being at the table for it is another. So be present and seek to understand by raising questions and sharing reflections openly. I think while the next setting is reserved judgment, and that's always the case, but it also doesn't mean that if you do have questions or concerns that they shouldn't be raised. So making sure that those things are addressed now so that they don't become a roadblock or a barrier in the future. And finally, start small, but just start. I hear teams all the time say, well, we're not yet, or we don't want people to see, that we don't have our stuff together. But really, you have to start before you're ready, because if you wait for all of the stars to come into line, that will never happen. So start small, but just start. So I know that this was a very kind of 10,000-foot level overview of what's been going on nationally and who are some of the leaders of this work. In our upcoming webinars, we'll be talking more of the nuts and bolts. So we have to prepare providers and also how to select and orient and engage patients and families. So I hope that folks will join the upcoming webinars, but Kiva, I don't know if we have any questions or if we want to open things up to questions.
Well, at this time, if there are any audio questions, I'd like to let the operator know that we can now open the lines for questions. And I also would like to remind you that you may submit questions to the speaker as well at any time by typing them through the chat feature located to the left of your screen.
And we have such a great group on today. I, would welcome folks to, share any successes they've had or any barriers they have experienced, and if there's, any just learning you want to share too, even if it's not a question.
I'd just like to let the operator know that we're ready for questions at this time.
Yes, ma'am. If you would like to ask a question, you may do so by pressing star 1 on your telephone keypad. If your question has been answered, you can withdraw your question by pressing the pound key.
And while we're waiting for any audio questions, I'd like to start with the first chat question for you, Tara. This question is from Bobby Pineda, and it says, are there specific funding sources that are good for applying for funding for patient-engaged research?
Yeah, that's a great question. One of the funding sources that is very specific to patient and family-centeredness is CORI. So that is the Patient-Centered Outcomes Research Institute. And they love to support comparative effectiveness research. And so anyone who's looking to do that and really engage patients and families at all levels, they have many rolling opportunities for funding. So that's a good place to start to look to see what options might be available. I know others, and I know the question was specific to research. So, any private funders who do a lot with, community support, grant support are good places to go to for patient-family engagement, research dollars. And more, I think, you saw my list of leaders in this work who are really investing in patient and family engagement. And a lot of what I've seen from them is now you'll see in research in grant applications that they'll want to know how you're going to engage patients and families. And so, there are always places to look. I know, at different times, Robert Wood Johnson has been a great place to look. If you're just looking for ways to fund patient and family engagement efforts locally, to say, we really want to start up an advisory board, but we don't have any money to pay for parking or things like that. Connecting with volunteer services, and we'll definitely talk about this more on future webinars too, but that is a great place to go for funding because they often have kind of a pot of discretionary money that they can use, or they can put patients and families through as volunteers so that they can get their parking paid for and a meal paid for, things like that. Also hospital relations or patient relations departments or patient experience departments are good places to reach out to. Communications and marketing department within a hospital sometimes has a budget for this type of thing. And then just reaching out to organizations in the community. So I hope that kind of provided somewhat of a direction, and if there are any more specifics about that, I'm happy to answer.
Thanks so much, Tara. We have another question for you from Annette Bay. And the question is, how did you identify disease or condition to target? And sustainability, can you address that as well?
So, I think in terms of the conditions to target, in terms of the Perinatal Quality Collaborative and what we're doing right now, so we have 2 current clinical initiatives we're working on. One being preeclampsia that I mentioned, and the other being neonatal abstinence syndrome. And so helping to provide support and education and improve outcomes for babies going through withdrawal. They were areas of focus that were identified by our state as, these are clinical areas that we feel we need to focus on. So the identification was really driven by clinical need in our state, not at all by patient and family kind of engagement needs or where we wanted to go in terms of that route. Of course, our goal is always to reduce mortality and morbidity and perinatal care, and so that's where we tend to drive towards. And so the patient and family engagement part of it just comes along with whatever our clinical topic that we've chosen. So, obviously when we talk about neonatal abstinence syndrome and we're telling teams you need to find a family member to be part of your team, it's a population that has less stability in their lives, and so it's, much more challenging. These are family members that challenge staff at the bedside, and so it definitely wasn't one of the easier places for us to start in our patient-family engagement. But it's also, the patients we have been able to partner with, it's been some of the most rewarding from what we've learned from them, and they're authentic and just the vulnerability they're willing to share with us. So that's really how the clinical areas are chosen. In terms of sustainability, we, and I'm not sure if the question was generally about sustainability for the Quality Collaborative or specific to patient and family engagement. We have very purposefully laid out in all of our funding requests the need to engage patients and families, and that they are a vital part of these efforts. And so my position and the, whether it be money to cover the learning sessions or webinars or things like that for patient and family engagement have all been a part of those budgets. And so, I think those who have funded us, they've seen the patient-family engagement aspect of our work as an asset, and has maybe helped us in getting funding.
Thanks so much, Tara. I believe we have another question for you on the chat side of questioning, and this question is from Patty Lee King, and the question is, hi Tara, thank you. Do you have any examples of hospital teamwork on patient and family engagement activities around the conservative management of preeclampsia?
Hey, Patty. So a lot of what the teams have been working on in terms of preeclampsia has been around the education materials. So I know a lot of folks out there, have used, California's great toolkit had a lot of educational materials that came from the Preeclampsia Foundation that they had adapted in that. So the teams that are working with patients in CMOP have tended to be spending their efforts on working on those materials, because one of the things we've heard a lot about those materials is that it needs to not be kind of a, here's a piece of information, here's another brochure that I'm putting in this stack of papers for you to take home with you at discharge, that it really needs to be customized to the needs of the specific patient. And so not just a general, call if your blood pressure is between this and this, that it is, this and this for you, specifically Tara Bristol as a patient, because we know that every patient's a little bit different. So I know that some of the teams are working on that, just how do we really make this customizable for the patient needs. And then, the very tricky part is, how do we make sure, and we've run into this with neonatal abstinence syndrome too, how do we ensure that the staff are utilizing this and going through this at the bedside with the patient? Just because we have a great tool or material, like for the teams that have developed who are using modified Finnegan, have adapted, created scoring sheets for parents to use. So they observe how their baby's doing and are able to write that down. But staff aren't always introducing that to the family, and so it's not being used. And so I think beyond just the creating of these things, it's getting through the challenges of, from the patient perspective, how could we more easily get these into your hands in a way that they'll be used. So that's where we are right now. I anticipate as we keep doing this work that they'll start looking at other ways of engaging on the preeclampsia project.
That's fantastic, Tara. Thank you so much. We're going to give you another opportunity. If there are any other questions, you can ask at this time by pressing *1 for audio questions. You may also ask a question via the chat function. And if there are no further questions, we'll go ahead and conclude our session today. First, I'd like to thank Tara Bristol for giving us such an excellent presentation on perinatal quality improvement initiatives addressing patient and family engagement. We'd also like to thank you all for participating in this webinar and invite you to provide feedback about this presentation and this webinar series as a whole. We'll be contacting you after this webinar for your input. We hope that our webpage and this webinar series will facilitate exchange of information and promote visibility of perinatal quality improvement activities throughout the country. We encourage you to join us for the next webinar in this series entitled Training and Supporting Providers for Successful Patient and Family Engagement. You may also visit our webpage for further details about upcoming webinars and information to learn more about how CDC is supporting perinatal quality improvement collaboratives. Thank you again, and have a wonderful afternoon.
Ladies and gentlemen, that does conclude the webinar for today. We thank you for your participation and ask that you please disconnect your line. Presenters, please hold.